even an older patient, is a 91-year-old lady, hypertension, all the comorbidities, but of course 91, fragile lady that's presented and with non-STEMI and heart failure, and some ECG changes and troponin rise. In the echo, she had anterior hypokinesia and apical akinesia and a left ventricular ejection fraction of 40%, so some depression of the left ventricular ejection fraction. And the angiogram, as you will see, she had very severe calcification of the vessels. She had severe stenosis in the 3 vessels, LAD circ, and a CTO of a small right coronary artery. So after discussing her case in the heart team, we decided to treat the LAD and circ. And as you will see, this is the type of vessels we find in these patients. So it's very small vessel, severely calcified at different points. And this is the first angiogram you can see. We pre-dilated everything with a small balloon. This is a 20 millimeter balloon. And this is the first image with OCT after pre-dilation. Sorry, because it's going to go a little bit faster, but we will focus. You can see that, again, there's a lot of calcium, and especially at the region of the minimal luminal area, there is almost concentric calcification. We will focus now in the most important parts. You can see in the proximal part, there is a lot of calcium, but at this level, the lumen is still quite good. If we go to the area of the minimal luminal area, of the area of more stenosis, you can see here this calcium. This calcium is actually so thick that you don't really see it very well. So it may be confusing maybe for some people, and maybe confused also with all the types of plaques, but this is really thick calcium located in this area. In this image is more clear that there is a lot of calcium, around 270 degrees of calcium. And here again, you can see in this area is almost concentric, this area around the diagonal that was protected. So again, based on the amount of calcium and characteristics of the calcium, we thought IVL could be a very good tool here. So this is application of IVL with a 2.5 balloon in all this region of the calcification. And this is the result after IVL. And this, as you can see, we have immediately obtained a very significant increase in lumen area. We have good flow, there is no reflow or any other thing. And this is the pullback after IVL. So you can immediately see the significant increase in lumen area and also the fractures. It's going to focus here in some still images. Again, here at around 5, you can see this deep fracture in the calcium. And here, if you compare the baseline and post-IVL, we can see the significant increase in lumen area and these fractures generated by shock wave, similar in these other 2 co-registered frames at baseline and post-IVL. Very significant increase of the lumen area and fractures. So after that, we implanted a 2538 stent, and still you can see that there, in this area of the minimum stent lumen, there's still some indentation. We implanted another DS distal because there was some dissection, and this is again very frequent, even in a patient where you're using imaging to size the stent, etc. There is so much disease, diffuse disease in the vessel, that dissections can happen. So we implanted another DS in this distal edge, and we did it both with a 3.0 non-compliant balloon. And this is the result by angiography that looks pretty acceptable, and you can also confirm this with OCT. We achieve a good stent expansion along the lesion, good apposition. Sometimes areas of malapposition, as I mentioned before, related with the irregular shape that is generated by the presence of calcium protruding in the lumen, but good areas and adequate expansion in the LAD. This is one of the frames, and as I said before, this is these areas where you have some protrusion of calcium, and you get these areas of malapposition generated by the calcium. And then we had to move to the circ. So this is also important. These patients frequently have multi-vessel disease, also like the case presented before by Kevin that had also 2-vessel disease. In this case, we had the opportunity to treat the 2 vessels in one session because really treatment with IVL in the LAD simplified quite a lot the treatment of the LAD. So after pre-dilation, this is the pullback in the circ. And again, you can mainly see a lot of calcium that is very thick. You can see that here is more eccentric, but is very thick. In other areas was more concentric, but basically eccentric calcium, very thick. And again, this is an indication to treat with IVL. And here we were lucky because we had still pulses in the balloon. So we used the same balloon to treat both lesions. This is, again, the application of the 2.5 IVL balloon. And this is imaging after shockwave. And again, you will see, similar to what we have seen before, the presence of fractures and calcification. It's interesting to see that when the pattern is more eccentric, thick, like in this case, you see less fractures, but as I mentioned before, more dissections at the edges of these eccentric calcifications. And in some areas, it looks like it's not really modified, but there is an increase in the lumen area. After that, we implanted an stent, 275/18, based again on the measurements we have performed with OCT, and this is post-dilation with an NC30. And this is the result after post-dilation. You can see that the again is good implant, is good opposed and expanded all along the lesion. These are some still images representing that. There was a small dissection at the distal edge that was not very deep and quite localized, and we decided not to treat that, or because it was very close, as you can see, to a bifurcation. We thought it was not necessary. So this is the final result. So the messages from these two cases for me is that severe calcification, as we all know, is frequent in old women with coronary stenosis, fragile women like these two that I presented. The main challenges, of course, for the treatment of this lesion in women are related with vessel size and tortuosity. You can see that still, even with very careful sizing, it's very easy to dissect a little bit these vessels. And I think in these patients, IVL provides a useful tool with a good safety profile for the treatment of these lesions in this population. So thank you very much.